Hi guys, welcome again to our presentation on the sacroiliac joints. We are still on the evidence-based mechanical diagnosis of sacroiliac joints. In our previous video, we've talked about how we can use subjective assessment, how we can use different palpation tests, how we can use provocative tests. We highlighted the strength of evidence of using these different tests, and then we rounded up by stressing the recommendation of the International Society for the Study of Pain, which says that you must rely on the subjective assessment, subjective report about the location of pain, the provocation test, and then before you now move to doing injection, sacroiliac injection, which of course is the gold standard for the diagnosis of sacroiliac. But in this video, we want to talk about yet another technique of making a diagnosis of sacroiliac joint. This is called MDT, mechanical diagnosis and treatments option for the sacroiliac joint disorder. Sacroiliac joint disorder, MDT, was first mentioned by the Swedish physiotherapist Sir Robin McKENZIE, and he used it exclusively to diagnose problems that are associated with the spine and the peripheral joint. And MDT emphasizes the use of repeated movements pattern to classify areas of problem with the spine and the peripheral joint into either posterior problem, dysfunction problem, and derivement problem. So this principle could also be applied to the sacroiliac joint. If we really want to know whether the sacroiliac joint is having a derivement syndrome, then we can use repeated movements of MDT to really get to know them. What do we do? Now, derivement syndrome generally is characterized by blockage of movements in a joint, either as a result of malpositioning of the joint or something blocking the movement of the joint. The blockage of the movement of the joint this time around could be the cartilage, it could be fat, it could be meniscoid, it could be a thickened capsule. Anything distorting the normal alignment of the joint or blocking the normal free range of movement of the joint in manual therapy term is called internal derangement. And McKENZIE categorized this as derangement syndrome. So what does McKENZIE want us to do with this? We're going to carry out repeated movement tests, and it is expected that one of those movement tests will actually make the pain better, and another movement test could make the pain worse. McKENZIE used the term centralization when the pain is made better, and peripheralization when the pain is made worse. Okay? So, as far as sacroiliac joint is concerned, we mentioned in our previous video, the two rotatory components of the movement in the sacroiliac joint are nutation and counter nutation. So if we want to apply MDT to diagnose whether SIJ is having derivement syndrome, we're going to ask the patient to repeat nutation or backward rotation or counter nutation, which is what? Forward rotation. And then we're going to ask the patient whether the pain increases or reduces. If we get a preferred pattern, then we can conclude that the patient is having SIJ derangement syndrome. Okay, Yusuf, for the forward rotation, please sit. Or you can lie down first. Let's start with lying down. For the on your back, Superman. For the forward rotation, or back, for the posterior rotation, which is also known as nutation, posterior rotation like this, which is also known as nutation, you can ask the patient to flex the knee, hold the knee on the affected side, and draw it closer to his chest like that. Let go. You're going to repeat that like 7 times. That's the second time. Go slowly. Third. Actually, you can go this way. Go the first time. Keep your legs straight like this. Then bend it. Then hug it. And push it closer to your knee. Now go again. Well done, Yusuf. Yes, you're doing it correctly now. That's the second one. So Yusuf is doing repeated posterior rotation of the sacroiliac joint or notation movements. Okay? If at the end of 7 to 10 movements, we ask Yusuf, how about your pain? If Yusuf should say that the pain has increased, right? So we are getting somewhere. He could either say that the pain has increased or the pain has reduced. Now, but the posterior rotation can be demonstrated in supine lying position. It can also be demonstrated in a seated position. Can you sit up with your leg at the edge of the planes, Yusuf? Now sit upright, chest out, move back a bit. A little bit to the front. Now you're going to grab your knee and pull it close to your chest. No, here. Draw it to your chest. And let go. And again. And let go. And again. And let go. And again. So for a patient with sacroiliac joint dysfunction, we want to know whether there is derivement syndrome. We can ask the patient to do repeated posterior rotation, which is also known as what? Notation. Yusuf can come up to say, oh, my pain has reduced or my pain has increased. There must be a preferred pattern. If the pain is reducing, McKENZIE called that centralization. If the pain is increasing, McKENZIE called that peripheralization. When there is peripheralization, it's an indication that there is an internal derangement. So in a way, it is a form of diagnosis. Okay? But if the pain is centralizing, then apart from being diagnosis, we're going to make use of that as a form of treatment. We don't talk about that in a short while. Our posterior rotation can also be carried out in a standing position. Yusuf, can you come here, please? Stand back to the wall, back to the wall, like that. So you're going to grab your knees and pull it close to your chest. Right, now and one, then we go again. Okay, and then we go again. And then we go again. Okay, so if Yusuf should do this one like 5 to 10 times, and we're going to ask him about his pain. If the pain is centralizing or the pain is peripheralizing. If the pain is peripheralizing, we can say that posterior rotation is causing pain aggravation. It could be a sign of derivement syndrome in terms of diagnosis. But the pain is centralizing. When the pain is reducing, we can actually advise Yusuf to use this movement at home to treat his sacroiliac joint disorder. What we'll simply say to Yusuf is to do 10 of this movement every 2 hours of the day, provided this same posterior rotation centralizes his pain. It makes the pain to come from distal side to the central part, or it alleviates the pain generally. What about anterior rotation? This is for posterior rotation. What about anterior rotation? For the anterior rotation, what is Yusuf going to do? How do we carry out the repeated movement? Yusuf, please come with me. You're going to go like half kneeling position. You're going to kneel down on the plane, please. I'm going to show you, don't worry. Thank you, Yusuf. Thank you, Yusuf. Now, if Yusuf pain is on this side, then this knee will be making contact with the floor. If Yusuf pain is on this side, then this knee is going to be down. So for this posture, we're going to assume that Yusuf pain is here. And Yusuf is going to place this hand on that sacroiliac joint. How do we carry out the repeated anterior rotation? Yusuf, you are going to lean forward on this knee and this knee. Just move forward. Push your body forward like that. That's it. And then you go back. That's one. Repeat that again. Okay. And then you go back. That's 2. And 3. And 4. And 5. And 6. And 7. And then Yusuf will go on up to 10, right? And at the end, we're going to ask Yusuf, how about your pain? You can say, oh, my pain has been made worse. That means the pain is peripheralizing. Or Yusuf will say, the pain I have in my SIJ is now going to my thigh. That is still peripheralization. That could be an indication that anterior rotation is experiencing some internal derangement. That's a diagnosis. But if Yusuf tells us, oh, after doing this movement, I can't feel my thigh pain again. I can only feel pain in my back, or I even feel this pain is less. That is what? Centralization. Then we are going to use this anterior rotation as treatment. Probably ask Yusuf to do this treatment, 10 of it every 2 hours of the day for his sacroiliac joint problem. Okay? So this is mechanical. You can sit down now, Yusuf. So this is mechanical diagnosis of sacroiliac joint problem using movement diagnosis and therapy as opined by McKENZIE. Now, before we leave the subject of diagnosis entirely, we're going to talk about yet what some of our colleagues usually said. I've been privileged to listen to some of my colleagues saying, oh doctor, before we do the manipulation, we look at the x-ray and we see the alignment of the sacrum and the ilium. The alignment is not perfect, and we carry out notation and counter notation, and after we do that and after all our treatment, we go back to take the x-ray again, and we still notice that the alignment is still not perfect. Well, you don't have to worry yourself about x-ray, about CT scan, about MRI when it comes to diagnosis of SIJ dysfunction. They might be very useful when we are looking at discogenic problem, when we are looking at spinal stenosis, when we are looking at facet joint problem in the lumbar spine. But when it comes to SIJ joint diagnosis, radiological investigation has little or no value. Why did I say that? The X-ray, the MRI, the CT scan cannot image pain. Patient is the only one that will tell us about the pain. That pain cannot be reflected on X-ray. Why did I say that again? Well, studies and experience have shown us that a lot of people that shows abnormal findings on radiological investigation do not have sacroiliac joint pain at all. Their radiological findings were so abnormal, but they have no symptoms. And studies have also shown that a lot of patients that have bad symptoms in the sacroiliac joint area have normal findings on radiological. As far as SIJ is concerned, radiological investigations are merely good to exclude other pathology, but it's not very useful to diagnose SIJ dysfunction. So when you carried out your manual therapy procedure and your patient get better, that is good enough. You don't have to worry whether post-treatment X-ray or post-treatment radiological investigation is still showing that the alignment is not perfect. Once the symptoms is reduced, I think that is good enough to go. So this is going to be a series of combination of tests that we have to do in order to be able to be sure in terms of whether the pain generator is from the sacroiliac joint. If it's from the sacroiliac joint, what is the pattern? Is the sacrum head in notation or counter notation? And what do we have to do about it? Thank you very much for watching this video.